Gastric outlet obstruction is a debilitating condition that arises due to mechanical blockage at the distal stomach or proximal duodenum, impairing the normal passage of gastric contents into the small intestine. The most common etiology of gastric outlet obstruction in adults is malignancy, particularly advanced gastric, pancreatic, and periampullary cancers. Due to the progressive nature of malignancies causing gastric outlet obstruction, the treatment primarily focuses on palliation to restore gastric emptying and improve the patient's quality of life. Gastroenterostomy has long been established as a surgical intervention for this condition, providing symptomatic relief by bypassing the obstructed segment and creating a direct anastomosis between the stomach and the jejunum. Historically, open gastroenterostomy was the standard approach to treating gastric outlet obstruction. But with advancements in minimally invasive surgery, laparoscopic gastroenterostomy has emerged as an alternative. While open gastroenterostomy offers direct visualization and reliable anastomosis, it is associated with a higher degree of surgical trauma, prolonged recovery, and greater postoperative morbidity. In contrast, laparoscopic gastroenterostomy is gaining traction for its minimally invasive nature, leading to reduced hospital stays, faster recovery, and potentially fewer complications. However, the adoption of laparoscopic gastroenterostomy is still debated due to concerns regarding technical feasibility, learning curve, and long-term efficacy in achieving symptom relief compared to open gastroenterostomy. This documentary explores the comparative analysis between open gastroenterostomy and laparoscopic gastroenterostomy in the context of palliative treatment for gastric outlet obstruction. It examines clinical outcomes, post-operative recovery, complication rates, quality of life improvement, and long-term efficacy based on extensive evidence, case studies, and medical data. The goal is to present an objective assessment of both procedures to guide clinical decision-making in the palliative management of malignant gastric outlet obstruction. A gastric outlet obstruction in malignancy is primarily caused by tumors originating in the stomach, pancreas, and duodenum. Among these, pancreatic adenocarcinoma is the most frequent culprit, accounting for approximately 60% of malignant gastric outlet obstruction cases. The obstruction arises due to tumor infiltration or extrinsic compression, leading to progressive symptoms such as nausea, vomiting, early satiety, and weight loss. As the obstruction worsens, patients suffer from malnutrition, dehydration, and a severely compromised quality of life. Studies indicate that more than 15 to 20% of patients with advanced pancreatic cancer will develop gastric outlet obstruction during their disease course. Without palliative intervention, survival and symptom control deteriorate significantly. In such cases, the choice of treatment depends on multiple factors, including the patient's overall condition, life expectancy, tumor burden, and institutional expertise in laparoscopic surgery. While endoscopic stenting has been proposed as an alternative, its efficacy is often temporary, with stent occlusion occurring in nearly 50% of cases within 3 months. As a result, surgical gastroenterostomy remains the most durable and effective palliative option for patients with a reasonable life expectancy. Open gastroenterostomy has been the conventional method for bypassing malignant gastric outlet obstruction for decades. The procedure involves creating a direct anastomosis between the stomach and the jejunum through an upper abdominal incision. This technique provides a definitive solution for restoring gastric emptying, ensuring long-term palliation of symptoms. The standard approach for OGE involves a midline laparotomy to gain access to the peritoneal cavity. The jejunum is brought up and anastomosed to the stomach in an anticolic or retrocolic fashion, ensuring an unobstructed passage for gastric contents. A Billroth II reconstruction is commonly performed to optimize the physiological drainage of the stomach. OGE offers several advantages, including direct visualization of the tumor burden, which allows the surgeon to assess the peritoneal carcinomatosis and potential contraindications for the procedure. Additionally, open surgery provides a stable and robust anastomosis with a lower risk of intraoperative technical failure. This is particularly relevant in cases with significant adhesions, extensive tumor invasion, or prior abdominal surgeries that may complicate laparoscopic access. While OGE remains a reliable procedure, it is associated with significant morbidity. Studies have demonstrated that postoperative complications, including wound infections, delayed gastric emptying, and anastomotic leaks, occur in up to 35% of patients. A study published in the Journal of Surgical Oncology analyzed outcomes in 140 patients undergoing palliative OGE for malignant GOO and reported a median hospital stay of 12 days, with an overall morbidity rate of 30%. Delayed gastric emptying is one of the most frequent postoperative complications, occurring in nearly 25% of cases. DGE prolongs hospital stays and delays oral intake, leading to increased dependence on parenteral nutrition. Furthermore, due to the invasive nature of OGE, recovery is often prolonged, requiring extensive postoperative care. Despite these challenges, open gastroenterostomy remains a preferred option in cases where laparoscopic surgery is not feasible, particularly in patients with large tumors, extensive adhesions, or compromised laparoscopic expertise at the treating center. The advent of minimally invasive surgery has led to a paradigm shift in the management of malignant gastric outlet obstruction, with laparoscopic gastroenterostomy offering a less invasive alternative to open surgery. LGE follows the same principles as OGE, but is performed through small port incisions, reducing surgical trauma and expediting recovery. Laparoscopic gastroenterostomy is performed using 4 to 5 trocar ports, with pneumoperitoneum established to facilitate visualization. The stomach and jejunum are mobilized laparoscopically, and an anastomosis is created using a stapler or hand-sewn technique. A Roux-en-Y or Billroth II configuration may be used depending on patient anatomy and surgical preference. One of the main advantages of LGE is the reduced operative stress, leading to lower inflammatory responses and enhanced postoperative recovery. Minimally invasive surgery also significantly reduces wound-related complications, which is particularly beneficial in palliative settings where patient frailty is a concern. A comparative study published in Annals of Surgical Oncology analyzed 98 patients who underwent LGE and found that the median operative time was 120 minutes, significantly shorter than the 160 minutes observed in OGE. The length of hospital stay was also notably reduced, with a median of 7 days for LGE compared to 12 days for OGE. Moreover, the incidence of wound infections was significantly lower in the LGE group. However, LGE is not without challenges. The learning curve for laparoscopic anastomosis is steep, requiring advanced surgical skills. Additionally, in cases of extensive carcinomatosis, laparoscopic access may be limited, increasing the risk of conversion to open surgery. Reports indicate a conversion rate of 10 to 15%, typically due to dense adhesions or intraoperative bleeding. Delayed gastric emptying remains a concern in both open and laparoscopic approaches, with studies showing no significant difference in the incidence of DGE between the two techniques. However, patients undergoing LGE tend to experience a quicker return to oral intake and reduced need for prolonged hospitalization. Ultimately, the success of any palliative intervention is measured by its ability to improve the patient's quality of life. Several studies comparing LGE and OGE have demonstrated that both procedures effectively alleviate symptoms of GOO, but LGE offers superior benefits in terms of postoperative recovery and reduced morbidity. A systematic review published in Gastrointestinal Surgery Today analyzed over 600 cases and concluded that LGE patients had significantly higher postoperative functional scores, reduced pain levels, and earlier return to oral feeding. These findings underscore the potential for laparoscopic surgery to become the preferred approach in eligible patients. While long-term survival in malignant GOO remains limited due to the underlying disease, achieving effective palliation is paramount. Both LGE and OGE provide durable symptom relief, with patency rates exceeding 85% at 6 months. However, given its minimally invasive nature, LGE is increasingly being recommended for patients with a reasonable performance status. The comparative analysis of open versus laparoscopic gastroenterostomy in palliative gastric outlet obstruction highlights the evolving role of minimally invasive surgery in palliative care. While OGE remains a reliable option in complex cases, LGE offers substantial benefits in terms of reduced hospital stays, lower morbidity, and faster recovery. The choice between these approaches should be tailored to individual patient conditions, institutional expertise, and the overarching goal of optimizing quality of life in palliative settings.